Hey guys, I'm gonna put it in the Discord as well, but for this, you guys don't have your cameras on. Just comment in the chat. Um, when either Hannah or somebody who's there, yeah. Okay, go. Y'all can leave.
Things, so people are coming up and raving about him in front of the love interests.
What do you make of that?
But narcissism too.
Yeah, yeah, it seems like it's persisting narcissism, but it manifests in a way that might be more socially appropriate than, oh boy, is that a teaching point? Right? I mean, that might drop him out of clinical care. It may reduce his level of distress. But it's persisting nonetheless, which is an interesting kind of, again, arc this movie takes. There is a scene, though, that maybe establishes something different. Although, as a hint, the writer-producer chooses not to take the out. The scene comes and goes, and there's really nothing much built on it.
Is it when he's hit on the head? In my mind, I'm like, they cover that very briefly, and you could say that's an explanation for why he's going through all this, but it was
could be a
very
clue.
brief.
I wasn't referring to that, but that's a good point. Right? With anything we're talking about, whether it's depressive disorder, whether it's a personality disorder, we have to make sure that the behavior is not the direct physiologic effect of a substance or underlying medical condition. In that case, it would be a medical condition, rule out traumatic brain injury. So that's part of the discussion, sure. By the way, if we think cluster B traits, where would we think the trauma would have occurred? Oh, no, I mean, in terms of, neurophysical. What below for the brain? Yeah, you'll see this come up on shelf exams, not so much in the context of Groundhog Day. But person with individuals with rapid onset and progressive personality change, cluster B traits, if not antisocial traits. And you're going to look for any evidence in that clinical vignette on your shelf exam as something that has a predilection for the frontal lobe and what's a very favorite board type of illness that might be in that vignette. Yeah, yeah. So inclusion bodies, right, upon biopsy, but any other guess as to what's seen? Everybody saw it, and it certainly goes against, or at least resolves everything we just said. But the writer-director chose not to make it the resolution. How about when he interacts with the homeless guy?
It was just coming to me.
No, I'm sorry, I spoke too fast, guy.
Like he really decides to make an effort with this guy. He over multiple, I guess, lifetimes or like days that he has the opportunity, he tries different ways to prevent him from dying. And it doesn't seem like he's getting, nobody's recognizing he's doing that. He's not getting that like social validation, I guess, that he gets at the end for like the various other things that he does. And it kind of made me, the way that he was like so adamant about it, it made me wonder if, it was reminding him of something in his life he went through or someone he lost, and like kind of trying to use this man as like a way to redeem something in the past that he was felt guilty about.
Yeah, I actually think you're right. And the reason why I believe there's supporting evidence to what you just observed and what you just stated is because if it were just his doing what he did with the homeless gentleman, that would have taken this movie in a different direction. That would have ended the movie, right? Once he puts himself in the service of others, our entertaining and considering narcissism is really out the window, right? It's complete opposite, right? He's empathetic, he's compassionate, and there's nobody around to actually pay attention and give him the external validation he doesn't need. But it doesn't end. So there must be something else with that interaction that we're missing, and I think you nailed it. I think it's his undoing, not a defense mechanism, and his having reversed something that in his mind was he was stuck at. And I think when he gets to that, but something happened that was in the prequel that we don't know, and certainly as part of a psychiatric evaluation, we would definitely inquire about. Other thoughts, continuing to focus on the character of Phil. Well, we mentioned a couple of terms before. It's probably a nice little window and opportunity to discuss what depersonalization is, what derealization is, and what depersonalization disorder is. Right. So what's depersonalization derealization disorder?
Where you don't feel like it doesn't feel like you're in your body. It feels like you're sort of observing things and you don't feel attached. You feel like empty.
Anything else?
Like you're in the passenger seat, I think, of your life, and then derealization, the world around you just doesn't feel real.
Yeah. So depersonalization, I think you're 100% correct and correct. Depersonalization, derealization disorder is clinically significant. Depersonalization and/or derealization. Keep it real simple.
Okay.
Then I'm going to ask, well, what is depersonalization? You nailed it. What is derealization? You nailed it. Right. So if you go in that three-step-wise progression, there's no way you possibly miss this on a health exam. Okay. Give me a short list of medications, or more specifically drugs, that can induce depersonalization, derealization disorder. Yep, first and foremost, right? Any evidence of hallucinogens in this movie?
I mean, he sure does experience a mystical episode where he relives the same day over and over again.
But beyond that, no.
No.
Any other drugs that you'd inquire about?
Alcohol.
Any alcohol in the fluid?
Yeah.
So we'll keep that in our differential. I think it's light, but
Mhm.
we may as well keep it in our differential. Any others? Cannabis? Yep. Cannabis, definitely, yep. Yeah, any cannabis in this film?
No. Although Bill known to partake, but no, not.
Any other? Any other drugs?
He smoked a cigar, but I don't know.
Tobacco now.
Okay.
Tobacco is definitely a drug of abuse, but not one that clinically we would consider inducing either dissociation or psychosis
Well-
because of the same thing.
Doesn't like ketamine induce dissociation?
So it's hallucinogen,
Oh.
right? So what are the three subclasses of hallucinogen? Well, inhalants is the other drug that can induce dissociation and or psychosis. So yes, that's another one. But with a focus on the hallucinogen, there are three subclasses we probably should know.
Ergotamines? No, is it not?
No,
like-
that's what, it's way too technical. You're gonna-
Okay.
Yeah, but yes, you're right. What might others call orgonomy? Psychedelics.
Okay,
That's a subclass.
okay.
There's two others.
So sorry, psychedelics would be like LSD as well. Okay.
Psilocybin, LSD, yeah.
You can't get more. Alcohol is what it is.
No, but if LSD is a psychedelic, what's alcohol? A
Beverage.
No, the
depressing?
psychedelics, dissociatives, and deliriums are all subclasses of hallucinogens,
Okay.
which along with alcohol make up the comprehensive list of drugs that's published in the DSM. To make sure we outline, right? Okay.
Can you give the examples of the dissociants and those as well?
Yeah, dissociatives would include PCP and ketamine, they're probably the top two.
Okay. And then what was the third one?
Deliriums, so antihistamines, anticholinergics.
Okay. It makes sense once you say.
I try it. Every now and then, every other Friday. Right, again, deliriums, dissociatives, and psychedelics. There are three subclasses of hallucinogens along with alcohol can induce psychosis. I think we're missing one. I heard inhalants. Yeah, but we're missing one. We're missing one other class of drug that can induce psychosis.
Narcotics.
No, opiates can't, no. Opiates, not thought to.
Amphetamine?
Yes, amphetamines or stimulants, yeah. Any evidence of amphetamines or stimulants in this movie? Yeah, no. So I mean, it doesn't really seem like it's a substance-induced dissociative disorder or psychotic disorder. Maybe that due to medical condition without traumatic brain injury, he does go for an MRI, right? There's nothing there.
What are they looking at, like an X-ray?
Yeah, I don't know, but there, yeah. Actually, it was an X-ray, it was an MRI. Yeah.
Brain
Yeah,
X-ray?
yeah,
Got a
yeah.
skull.
Yeah. But at least they had an idea, right? I mean, it's actually better than most movies.
Yeah.
So, they are investigating the potential role of an underlying medical condition. Good. What else then would be your differential for people who present with clinically significant depersonalization, derealization disorder? Well, the fact that I say disorder means that it's always clinically significant, so it's a little redundant, but other than substances and other than medical condition, trauma. So what are you thinking of there? If yes, then what? Let's say the prequel does have trauma.
PTSD has feelings of deep realization.
Yeah, a lot of people call it complex PTSD. The DSM does not acknowledge that term.
Mm.
They have a sub or classifier or specifier, depersonalization, derealization. Within the same chapter, though, there are other illnesses that we should consider. So there, for PTSD, and it's definitely in our differential, we would step outside of the chapter. But remaining in the dissociative disorder chapter, there are other conditions to consider here.
DID?
So DID, okay, do we feel as though that there's any evidence of DID here? Dissociative identity disorder,
No.
and there's one other we have to consider.
Dissociative
Dissociative amnesia, which may be with or without fugue. Any evidence of dissociative amnesia here? No, because he actually remembers, right?
Yeah.
So that's how I went to play the piano, he wouldn't be able to remember, right? So no evidence of dissociative amnesia, therefore no evidence of dissociative amnesia with the fugue. So just going through the differential, I think we leave PTSD in here. Only because we want to inquire about a history of trauma and then take it from there. But otherwise, maybe there's a role of alcohol, but not likely, or doesn't appear likely. But right now, I think we're landing on depersonalization, derealization as well. Any other thoughts?
A question. What do you think about him having an avoidant personality?
Avoidant personality disorder.
Simply because, he's very querulous, but, he frequents the attention of women. So it seems like he does want something, but it's all surfacey initially. What do you think?
Thoughts? Well, before we talk about, Bill, what is avoidant personality disorder? How will it appear on your shelf exam?
Avoidance, want connection and closeness with other people, but they have a fear of rejection versus like a schizoid who looks very similar, but they don't actually want to connect with people.
Yeah, and it's almost guaranteed that if you have a clinical vignette for which avoidant personality is the single best answer, answer B, answer A is going to be schizoid personality disorder, right? In both situations, the individual is socially isolated, but the avoidant personality is further defined as an individual who is conflicted and therefore wants interaction with people, but feels socially inappropriate and therefore avoids those interactions. Individuals with avoidant personality are likely to self-refer, albeit not necessarily for any clinical criteria defining the disorder per se, but instead anxiety and depression. That after a comprehensive psychiatric evaluation will be revealed due to those avoidant traits. It is better not to have loved at all than to have loved and lost. If I don't put myself out there, I can't get hurt. And that behavior gets reinforced because after a week, after a month, they haven't been hurt. So that's the way in which we can actually envision avoidant behavior, therefore avoidant personality developing through that reinforcement. That's negative reinforcement, right? It's the absence of something not this, the absence of rejection, negative reinforcement, perpetuating behavior. Is that what's going on here?
I don't think so.
People with cluster personalities are often alone, but the dynamic is that they push people away. People choose not to be around them. Keeping company with a narcissist is difficult sometimes. Borderline personality, difficult. And if that's the dynamic here, we're probably looking at cluster B, not cluster C. Make sense? Just because we're, again, using these big words. Other than avoidant personality disorder, what are the other personality disorders in cluster C that they're grouping? OCPD. Good. Obsessive compulsive personality, which is defined as what? Generally?
Egosyntonic. Yeah, where you prioritize like orderliness and routine and you just love it. And so you like really stick to it and it becomes annoying. To others.
Well, no, it could be a clinically significant stress or impairment is the defining principle here, right? Personality disorders are disordered behaviors.
Can we go over the difference between ego dyssyntonic?
Yeah, I'd rather not, because when we differentiate this condition of obsessive compulsive personality from OCD, which medical students will often remind me is ego dystonic, it's largely irrelevant. Because in one situation, somebody will present to you as a doc and say, the reason why I'm here, my chief complaint is that, again, likely anxiety, depression. And when you ask why, it'll be because I failed to meet deadlines at work, I didn't get my bonus, etc. And then it is revealed through further questioning that the individual is attention detailed and oriented, needs control, and is a perfectionist, and that is getting in the way. And that results in clinically significant distress or impairment in functioning, like vocational functioning, and now they seek help. Right? So it's the person who requires order, control, and perfectionism, right? Your type A personality. Then their monozygotic twin comes in an hour later, an appointment with you, and they tell you that they're here for the management of their OCD. And you ask, well, are you a perfectionist? Heck no, that's my brother. Do you require order and control? Heck no, that's my brother. Are you detail oriented? Nope, heck no, that's my brother. All right, why are you here? Well, I have these intrusive thoughts. My doctor says are obsessions. And I have these ritualistic acts that alleviate anxiety. My doctor says they are compulsions. I have OCD. One has nothing to do with the other. Right? OCD, if you ever forget the diagnostic criteria, it is literally written in the title of the illness. Clinically significant obsessions and or compulsions. About 10 to 20% have only one. 80% have both.
I think if you focus too much on the ego dystonic syntonic thing, it can get a little confusing. I did a question the other day where a woman had a baby and she was like obsessed with keeping the baby clean to the point where like it was becoming like untenable. Like she would like wash fruit 3 times and shower before she fed the baby. And I thought she was distressed by this. So I thought it was actually, I thought it was a delusional like situation. But it like the answer was that it was OCD. But I didn't understand it because she wanted to be doing it. Like she was. I feel like when you think ego dystonic, you imagine like, oh, they don't want to be doing it, but they have to. But she was very much like dedicated to like the cleanliness aspect. So I got like kind of thrown off by that.
Yeah. I think I remember that question. I think the like one liner there was like, she's afraid the kid's gonna get sick. I think that was like.
Yeah, like a fear.
Yeah, so it was the fear that was driving the actions.
Yeah.
And again, and I haven't seen the question, obviously, but what I would be looking for in that question is whether or not there are intrusive thoughts or obsessions, because then you're talking about obsessive compulsive disorder versus the personality trait of requiring perfectionism.
Yeah.
So that really does separate. The words obsession and compulsion are nowhere in the text, the DSM, in defining or describing obsessive compulsive personality. Right? They're in the title of OCD, and the clinical criteria. They are only in the title of OCPD. They're nowhere else found.
Well, often will someone have both?
You could have both, and why? So, and the answer is the same as to why we would name them similarly when they're clearly not the same. So, any ideas as to why? Why there could be comorbidity, and why would we name them similarly, other than confusing you guys for your shelf exam?
Both anxiety driven?
They certainly are. They certainly are.
So you could develop the personality disorder to manage the OCD.
That could happen. That gets the comorbidity. Etiology. From a biopsychosocial perspective, specifically psychological perspective, they're thought to share the common defense mechanism of isolation of affect. Right. So because you're having 2 different manifestations of isolation of affect, we name them similarly. That's just sort of the way that went down.
All right, can you describe that isolation of affect?
Sure. How many raise the hands? We have Chief fans in here.
Yeah, an Eagles fan.
I have my next one. So let's pick on the Chiefs. Mahomes is going to be dealt his first
Loss.
loss. And our Chief fan is going to come in Monday to work, and there's going to be people going up to them asking, "Did you catch that game?" No malice. It is a Super Bowl, and Monday morning people are going to ask, "Did you catch it?" For the Chiefs fan, in our scenario anyway, they may not want to talk about it. Right now, if it's a buddy of yours that you went to high school with, you might react in a certain way. But when you get to work and if you're wearing that white short coat, you might not say the things that you really want to say, right? So there's a few things you can do, right? There's a lot of options, one of which is to employ isolation of affect. And that is, as they're walking down the hall with you towards your less than amazing new clerkship, if you employ isolation of affect, you will take the affect or emotion and separate it from the idea of the Chiefs losing their first Super Bowl. Well, not the first, but the most recent Super Bowl. And you will isolate the affect or emotion in your unconscious. That allows you to talk about what it is that I want to talk about, that big no call at the end of the game, without being emotionally invested in it. Right? And that, if done repetitively, if it becomes a rigid defense, puts you at risk of developing both obsessive compulsive disorder as well as OCPD. And depending on other variables down the road, you'll go one way or the other, or both. That's isolation of affect.
So to flesh out the example, if you were like walking down the hall, would you isolate the feeling that you have? Like, oh, it's like a beautiful day. What a great, awesome day or something without saying it? Or would you?
No. You, if somebody presses you about that big no call in less than 2 minutes when the Chiefs were out of timeouts and all Hurts had to do was now kneel, victory position. Or victory formation. They'll say, oh yeah, I mean, I couldn't believe that Brett missed that call. Or it was really close, that could have went either way. I mean, they'll talk factually about it, but having separated the affect and isolated into the unconscious, they're not emotionally invested in the conversation. So it allows you to factually talk about something without being emotionally invested in it. That defense is called isolation of affect. Perfectly fine when adaptive. When rigid, and that's all you use, it becomes maladaptive and it poses risk. And the two potential outcomes that you're at risk of developing include OCPD and OCD. Or both.
Yeah, I think I'm just like missing the gap between how like separating an event and your emotion from it leads to obsessions and like perfectionism and.
Right, so more to talk about.
Okay.
So if you are not rigid in your defense, it's a one and done. You're on your way and there's nothing more to do. Unfortunately, in the scenario that we're going to paint, this is the only defense that you use. So this could become maladaptive because of its rigidity. The issue with isolation of affect is that the affect cannot stay isolated forever, right? So your friend brought up this idea and it's going to kind of linger with you. You could continue to isolate, but at some point that defense mechanism will be overwhelmed. And that feeling is going to come up towards conscious awareness. And when it does, you're going to feel anxious. Right? You have to employ defense mechanism number 2. Now, I want you to picture, if we can map this out, what inner chaos this must look like. Think about that for a second, of how you've isolated this emotion and it's trying to come up towards the cerebral cortex, and there's mechanisms in place to try to keep it down there. Total chaos. If the next defense mechanism is reaction formation, how will that total chaos be projected or be manifest?
You'll like you'll manifest it, you'll change the emotion, let something else out.
Well, remember the inner chaos. How will inner chaos be outwardly discharged with reaction formation? What's the opposite of inner chaos? Well, what's reaction formation?
You do the opposite.
Right. So what's the opposite of inner chaos?
Inner calm.
Outer calm.
What?
Inner
Order.
turmoil.
One more time, real loud.
Order.
And there you have that cardinal trait of the obsessive compulsive personality. On the other hand, if not reaction formation, if the other defense that you happen to employ is undoing, the ritualistic act of living anxiety, specifically the anxiety of that isolated affect coming and yearning for conscious expression, you can see how you might begin to count or check or claim. That's OCD. Right, so it really depends on the secondary defense employed. Okay.
Yeah. Thanks.
I have no idea how we got here. Back to Phil. We're still talking about Phil. Any other characters? We're kind of coming towards the end here. We're already past the bottom of the hour. So, any other characters you want to focus on and discuss before we end?
Feels a lot of interest.
Rita?
Wait.
Rita? What's going on with Rita?
Well, Phil becomes interested in like trying to woo Rita. And I see, I feel like you referenced the homeless person, but I feel like part of his change is like in trying to
Impress her.
yeah.
and then going throughout every single day, taking the information that he gets from her and using it as like manipulation.
Yeah.
That just speaks a little bit more to his narcissism and just solidifies that.
You know what would be kind of interesting is that, and this would have been a blooper, but there was one of the 100+ recurrences that Rita built on. Right? It would have been easy to miss, right? But if it's there, the whole dam breaks and that she remembers what that means. So it doesn't happen, but next time you watch, and you guys should be watching February 2nd, right? It's not the first time. Look for it. So I'm not gonna talk more about that, but if there's one shred of evidence that she remembers one thing, this idea that it repeats for her is over, and she's in Phil's.
Are you saying there is no
I'm
special?
not saying it. I'm saying next year at this time, you'll be an M4 and you have my number.
She does mention that she feels like deja vu after one point.
Which is depersonalization, right? Deja vu is one example of depersonalization.
But is it because he's artificially like said something that would have entailed that they would have had this conversation before? Like, you know?
Tell me when you watch it. Any other observations? I'll read that. And we'll leave it there. Bottom of the hour, so. Good luck on your shot.